Hey everybody, it's Dr. Wood again. Let me know if you can hear me, if you guys are able to see the screen and all that good stuff. Perfect. All right. I'm back in my normal environment, so hopefully everything will sound and look as good as it normally does. Not on the road like I was last week, so hopefully that'll help out a bit. I'm going to start here in just a minute. We'll finish up the section here about drug dosing, and then we'll get into the next part where we actually get into real drugs, which is pretty cool. And then that'll be the material for the exam. So just so you guys know the plan. Again, if you have questions, put them up in the chat or onto the sticky board. Either way works for me. Get your questions in because this is the last chance you'll have. You'll have your tutoring session, which fortunately he already knows kind of what's going on in terms of how I ask test questions, but you know, it's good to get it from the source first if you can. All right, so it's 8 o'clock. Let me go ahead and start the recording here. Okay. Let's see, I think we left on controlled substances, did we really? Okay, I can do that. All right, perfect. Thank you for catching that. All right, so here we are. So last time we were talking about a bit of a hodgepodge of topics. We talked about writing prescriptions. Now let us get into talking about controlled substances. Now, it's kind of a misnomer because, I mean, most prescription drugs are controlled to some extent, but this is more in regards to talking about things that have a tendency to be abused or can be potentially addictive, habit forming, you know. So these are going to be our controlled substances. They have a tighter control on them, and this is through the Drug Enforcement Agency, or the DEA. So, and we'll find out that there's some differences between, say, like state and federal laws, but we'll mainly focus on the federal side of things here just right now. So anyway, when I say controlled substance, again, I mean a drug with a perceived potential for abuse, whether that means patients are taking it for euphoric sort of purposes or because it makes them feel good, or if they are abusing it. Say, for instance, they have an untreated pain condition and they're self-medicating, and then that leads to physical dependence and addiction. That is sort of what we're talking about here. There's 5 main schedules in terms of what we will categorize our controlled substances as. And so it goes from 1 through 5, 1 being sort of the highest potential, with 5 being the least potential for abuse. And so one big delineation here you want to make is between Schedule 1 and Schedule 2. Schedule 1 and 2 are kind of similar in terms of their abuse potential, but there's one sort of notable thing here is that Schedule 1 substances do not have an acceptable medical use. So, for instance, something like morphine, which is highly habit forming and highly likely to be abused if used incorrectly, that has an acceptable medical use as an opioid analgesic, right? So you can give morphine for pain, and that's totally acceptable from a medical standpoint, assuming you have all the right credentials and all of that. On the other hand, though, something like heroin, which is typically not available in medicinal preparations, you know, it's typically bought on the street, things like that, that does not have an acceptable medical use. So morphine would be a C2, whereas something like heroin would be a C1, okay? And it's always a crime to have, you know, a C1 in your possession. That's a felony, so they're very hard to get a hold of, very difficult to do any research with a lot of Schedule 1 substances. And so I'll talk about some other examples of that and a little bit later. Now, as you get into 3, 4s, and 5s, they're going to have less risk for abuse and less risk for dependence there. 3 having more so than 4 and more so than 5. And so 5 is kind of the least amount, but you'll see in terms of how we're actually controlling these that C1 you're not really ever going to deal with in terms of from a medical standpoint. C2s are going to have sort of the highest regulation around them, and then 3, 4s, and 5s tend to get sort of lumped in with one another there. So anyway, so what's our requirements here in terms of Florida? There's a few additional requirements you may see on the actual prescriptions themselves. So for instance, here you see they have to have the name and the full address of the patient to make sure that we know exactly who is getting it, to make sure we have the right person there. Or in some cases, if it's the owner of the animal who's getting it. And you may say, well, that's crazy. What kind of animal would need controlled substances? So usually it's like a seizure disorder or something like that. So if a dog's getting phenobarbital, which is a seizure med we'll talk about later on, that could be an instance of that. And then the species actually has to be specified on there, whether it's a dog, a cat, a guinea pig, platypus, whatever happens to be, right? And then you have to add the full name and address of the prescribing practitioner. So that would be you if you're the ones actually writing that. And recall that Florida, although we are generally late to the game in terms of advanced practice practitioners, you guys can now register for a DEA number and can prescribe controlled substances as long as it's within your scope of practice and all of that. You don't want to have someone who's in behavioral health writing for pain meds, right? So it needs to be within your scope, but you also have to have a DEA number. That's something you're assigned individually when you get registered with the DEA. And there's some other educational requirements and stuff, but that's basically that. And then the other important thing here is you need to have the written and the numerical quantity to dispense. So you don't want it to write down the number 10 and then someone writes down a 0 behind that and all of a sudden it's 100, right? So you don't want anyone to be able to manipulate your prescriptions, and so you have to write out TEN and then actually write the number 10, and so that way you can limit how much sort of trouble someone can get in with altering your prescriptions. Other things to note here, if you recall with prescriptions, that they're only good for a year for non-controlled prescriptions, whereas it's going to be more limited in terms of writing for controlled substances. So a year for non-controlled prescriptions. For schedules 3, 4, and 5, you're going to see here that it's going to be for a maximum of 5 refills because the script is only good for 6 months. So even if it's something they're taking every single day, you can only write for that original script and then 5 refills for a total of 6 months. That's one notable difference here between scheduled 3, 4, and 5 drugs and non-controlled drugs. Now with C2, it gets even more tightly regulated because of the fact that there's an inherent higher risk for abuse, at least according to the government who's setting that up. And so with the Schedule 2, there's no refills you can write for that. Even if you wrote down 12 refills, no pharmacist is going to honor that. And they can be only written up to a 90-day supply, which is important. You can actually break this up into multiple scripts there. So for instance, I could write, not me personally, but if I was a practitioner who had a DEA number, I could write down 3 scripts for 30 days a piece for a C2, and then say, on the first one, they could fill it today. On the second one, I would say, do not fill until 1 month from now. And then on the third one, I would say, do not fill until 2 months from now. And you'd actually write that date on there. It also has to be written on tamper-resistant security paper. So that I will show you an example of what that looks like here in just a moment, but it has to be on the special type of paper that is also regulated, and then it can't be transmitted over the phone. So no one's going to be calling in, a morphine prescription or an oxycodone prescription over the phone, because again, when I pick up the phone, I don't know who I'm talking to. It could be anybody, and just because they sound official doesn't mean that they are, right? So they have to actually have that paper and bring it in. There's starting to be some more tightly controlled electronic means for transmitting these, but it's less common than just having the patient bring in the paper script. Here's an example of what the counterfeit, I should say resistant, not proof, because really nothing is completely proof, paper here. And if you notice, if you try to copy this, it'll have like void written all over it. So that way it's easy to tell if someone tried to copy and then take it to a different pharmacy or something. And so it also has all of your information already put on there and printed out. So because it comes from a specific vendor that the DEA can track for. It also has to be hand signed by the provider. So if you can't like stamp it or try to do some kind of electronic signature, it has to be hand sign for those C2s especially. And so again, if you're using or writing for a controlled substance that's not being electronically transmitted, meaning even if it's at 3, 4, or 5, but you're actually putting it down to paper, it has to be on this type of paper here. So that is one of the regulations. So question is like, well, what are some controlled substances? And we'll get into them later on when we get into specific sections here, but just to kind of give you some context for what you might think of as controlled substances. Things like morphine, right? Morphine is a opioid pain medication, but certainly we know opioids are highly addictive in certain susceptible populations. So morphine is actually going to be a C2, right? So it's very tightly regulated in terms of writing for scripts for it, right? Which can make it a pain, especially for patients who have legitimate chronic pain issues. It makes them very difficult for them to actually get a hold of those scripts in some instances, especially if they're traveling and things like that. How about cocaine? You think about cocaine, you think about, TV shows and detective shows and things like that. C2, cocaine is actually a C2. Funnily enough, you might think it's a C1 because you always think about it in terms of the illicit use for it, but it's actually a C2. There's some limited cases where you can use it for like ENT surgeries. Cocaine's actually a pretty good anesthetic and a vasoconstrictor, so it actually helps with surgical cases and things like that, preventing bleeding and whatnot, or limiting bleeding. Methamphetamine. Actually, your amphetamines for the most part are going to be a C2, right? If you think about a lot of your ADHD medications, they actually come from the amphetamine category, and so they again can be highly addictive if used incorrectly, and so that's going to be something you'll see with that. And so I'm trying to lower my gain here on my mic a little bit. It looks a little hot on the monitors, but anyway, yeah. So methamphetamine and other amphetamines tend to be a C2. And so that can be a problem for kids with ADHD that are trying to get their meds, throughout the school year. And marijuana is kind of an interesting one. Federally, it's actually still a C1, so it's actually federally still a crime to hold on to marijuana. But it's been one of those interesting things where they're kind of allowing the states to do their own thing. And so in some places, it's only allowed for medical use, like we have here in Florida. In some cases, it's completely decriminalized and available for recreational use. So think about places like Colorado, for instance. So again, sometimes it's state to state. Typically, you want to go with whatever has more strict regulations, whether it be federal or state. But in this case here, marijuana is kind of the odd ball out. Anyway, you may find different states have different schedules. So, for instance, like carisoprodol is a muscle relaxant, otherwise known as Soma, and that's actually a C4 in Florida. They saw, enough abuse of it. They said, let's go ahead and more tightly regulate that. And there's been changes to the schedule too. You may see this over the course of your career. So, for instance, like hydrocodone in combination with acetaminophen used to be like one of the most common drugs prescribed. It was always at the top of the top prescribed drugs every year, it's otherwise known as Lortab or Norco. They saw a ton of abuse with it as a C3, so instead they bumped it up to a C2 to more tightly regulate it, and that's actually seen pretty big drops in prescribing trends there, which is interesting. Tramadol is sort of like a wimpy opioid. It used to be unscheduled, and so it's quite popular for people like PAs and nurse practitioners to write for because they didn't have to have a DEA number. In Florida for quite a while, we did not have any sort of means for advanced practice practitioners to actually write for controlled substances. So that's changed now, but tramadol actually got bumped up to a C4 because they did see a decent amount of abuse with it. So things change over time, just kind of the nature of the beast. Anyway, let's talk about our drug dosing here now. This will be useful for your calculation portions of your prescription assignments, which I think is due next week, if I recall. So you can try that out. Let's say, for instance, though, we have a 15-kilo child. Again, always stick with your kilograms. We have to stick with the metric system here in medicine. They require amoxicillin, which is a pretty typical antibiotic used for acute otitis media. They're going to be getting a dose of 90 milligrams per kilo divided twice daily, BIDs twice daily, and it comes as a suspension of 400 milligrams per 5 mLs. So how much should this patient receive per dose, right? Again, when you're actually writing these scripts here, you want to write out the actual volume that the patient is going to administer, or the parent or whoever is going to be giving to the patient, right? Because I could tell them, hey, you know, go ahead and give them 300 milligrams. But if they don't know how to convert that over into a volume to actually measure out, it's not going to do them a whole lot of good. And you have to assume you're dealing with people that don't have a lot of prior knowledge to make this work. You want to make it as simple and foolproof as possible. It's difficult to do, right? But first off, what you want to do though is figure out how many milligrams the patient actually needs to receive per dose, right? And so this is where it gets a little tricky, because when you're looking at this, you notice it's 90 milligrams per kilo per day divided BID. We want to figure out what it is per dose. So we got to convert this from per day to per dose, right? So there's a few different steps you could take. First, you could go ahead and multiply it out by the patient's weight. So you can take that 15 kilos times 90 milligrams per kilo per day to get the total daily amount. Or I could just go ahead and convert this 90 divided by 2 and get 45 mg per kilo per dose, and then multiply it by the 15 kilos. Either way, you're going to get the same response or the same answer, so it doesn't really matter. So we have our total daily amount the patient's going to be receiving, and then we can then divide that BID, so they're getting 675 milligrams per dose, right? Again, if a step doesn't make sense, go and let me know, and I'll go back to it. So now we got to figure out the conversion going from the milligrams per dose to an actual ml amount, the actual volume we're going to be administering. And so this is where it gets a little tricky, because you got to know how to actually convert this over appropriately. Once you know how to do it, it's simple. You know, I was just working yesterday at the Children's Hospital, and we do this all day long, basically. And so you get very used to it over time. But as you can see here, the suspension comes as a 400 milligram per 5 ml suspension. Now, if you notice here, most things will have like per 5 ml, especially oral liquids. This is because people are used to dosing like in teaspoons and tablespoons. For your information, a teaspoon is 5 mLs and a tablespoon is 15 mLs. But we don't really dose in teaspoons and tablespoons much anymore, because depending on the spoon you grab, whether it's from, I always use the example, whether you get a spoon from Walmart or you get a spoon from IKEA, maybe that Swedish spoon is measuring differently than the American spoon. Spoons are not a very good means of measuring accurate volumes, and we like to strive for accuracy here. So instead, most of the time you're going to see like dosing cups that have demarcations on the side to show you the volume, or they may have dosing syringes, which I like the most because they are the most accurate. So dosing syringes are pretty good. You'll get them from most pharmacies when you pick up one of these scripts. Regardless though, so what I like to do is always convert, when it says per 5 mLs, I convert it to the per ml amount. So again, we know we're getting 675 milligrams per dose. We can go ahead and divide this out. 400 mg per 5 mLs, that's 80 milligrams per ml. That's the concentration we're dealing with. And the important thing when you're doing these conversions is to follow your units. Make sure things cancel out to get what you're finally looking for. So if you're ever asked a question of like, well, how many mLs per dose does this patient get? Your unit should cancel out to the point where you just get mLs per dose as your final answer, right? So what we're going to do is take that 675 milligrams per dose. We'll then divide that by the 80 milligrams per ml. Because we're dividing by this, the milligrams will cancel out and the mLs will go up on top in the numerator. And so this will just turn into 675 divided by 80, get 8.4 mLs per dose, right? And that's your answer. That's what you'd write. You'd write amoxicillin, 400 milligrams per 5 ml suspension, take 8.4 mLs by mouth twice daily for how many ever days. And you have your quantity based off of how much you're getting per day times how many ever days, and then your refills and your signature, and that's it. That's your whole script, right? So I'm gonna always include the pediatric dosing prescription on your prescription assignments going forward, just so you get that practice there. So let's say, for instance, we change up a little bit. We have an 18 kilo patient that needs ranitidine. This is a bad example because ranitidine was just recently taken off the market this year, but we're using it for GERD symptoms, right? So a kid's getting some acid reflux there, and they're getting 4 milligrams per kilo per day divided BID. It comes as a syrup of 15 milligrams per ml. How much should they receive per dose, right? And so I'm going to show you if I can get my calculator up here on the screen so you can check that out. 1 second here. All right, so you guys should be able to see the calculator here over on the side. So how are we going to figure this out here? So basically what we're going to do is we need to figure out how much they're getting on a daily basis, right? So we can go ahead and do our 18, let's see, 18, and we're going to multiply that by that 4 milligrams per kilo per day, right? So multiply that by 4. So we know they're getting a total of 72 milligrams per day. We also know they're getting it twice daily. So what I can do is then divide that by 2. So I can divide it by 2, and they're getting 36 milligrams per dose, right? Because it's 2 doses per day. So those cancel out and you get 36 milligrams per dose. Now I know that they have a ranitidine syrup of 15 milligrams per ml is my concentration. What you note here is that I don't have to divide by 5 because the concentration is already in per ml, so I don't have to worry about that. I can take that 36 milligrams per dose and then divide that by 15 milligrams per ml, and then I ultimately get mLs per dose, right? So I take that 36 and divide that by 15. I get 2.4. So on my script, what I would write would be ranitidine syrup, 15 milligrams per ml. Take 2.4 mLs by mouth twice daily. However often they're doing that, right? So that's basically how that would go. So 2.4 mLs would be the correct answer there. I'm going to leave these on the prescription assignments. I'm not going to have you to actually calculate out these doses on the test itself. If I do in the future, I'll certainly give you plenty of heads up, so don't worry too much about that for sure. So let's see what else we have here. Let's say we have another one here. We have a 12 kilo patient who's receiving trimethoprim sulfamethoxazole as another antibiotic for cellulitis. They're getting 4 milligrams per TMP per kilo per dose BID. You're like, what the heck does that mean? Well, sometimes when you find combination products, so in this case here, it's a combination of 2 antibiotics, trimethoprim and sulfamethoxazole, you'll find that it's dosed, it's in a fixed ratio here. So the ratio always is going to be the same no matter what kind of preparation you're dealing with. And so you can just dose it off of one of the components here. And so in this case, trimethoprim, which is abbreviated TMP, is the most common one you're going to see here. So they're getting 4 milligrams of TMP per kilo per dose. You can see here the suspension comes as a sulfamethoxazole 200 milligrams and trimethoprim 40 milligrams per 5 ml suspension, right? So how much should the kid receive? And this looks more complicated, but it's not really that bad because since I know I'm basing off the TMP and I know this comes as a fixed ratio, I don't even have to think about that sulfamethoxazole. Just go ahead and get rid of it from your mind, because when you calculate out how much trimethoprim they're going to get, they're automatically going to get that sulfamethoxazole along with it, okay? So let's go ahead and see how we're going to do this. Basically, what we're going to start off with is say that we have that 12 kilo patient. We know they're going to get 4 milligrams of TMP per kilo per dose. Now, one thing to note here, this gets a little complicated or a little more tricky, is because now I said per dose. I did not say per day divided BID. So now I don't have to divide by 2 because I already have this in a matter of per dose sort of units. When you are looking up this stuff, whether it be Hippocrates or Lexicomp, wherever you're looking it up, make sure you keep a good eye on this kind of stuff, because this is where a lot of dosing errors occur, is if you get the per day or per dose screwed up, and you're either giving twice as much as you mean to, or you're giving half as much, or 3 times as much, a third as much, depending on the frequency there. So be careful with that, okay? What I'm going to do is take that 12 kilos, I'm going to then multiply that by the 4 milligrams of TMP per dose. And now I get 48 milligrams of TMP per dose, okay? Now again, they're getting it twice daily already. So then what I can go ahead and do is say, okay, well, I know it's 40 milligrams per 5 ml suspension. So 40 divided by 5 is of course going to be 40 divided by 5, going to be 8. So I know that concentration of that suspension is 8 milligrams per ml of trimethoprim, okay? So I'm going to take my 72 milligrams per dose that I'm using. I'm going to divide that by 8 because it's 8 milligrams per ml. And I get 9 mLs. The patient should be getting 9 mLs of this combination of sulfamethoxazole and trimethoprim twice daily. So I'd write, Bactrim suspension, which is a brand name, 200 milligrams, sulfamethoxazole, trimethoprim, 40 milligrams for 5 ml suspension. They're going to get 9 mLs twice daily for how many ever days they're going to get it for. Okay, fairly straightforward. One other thing to see here is you could actually do this backwards. Actually, you could actually do this in a different way. So for instance here, we get this a lot in ERs where parents will come up. Where did I get the 72 from? That was that 4 times 12. I'm sorry, let me see here. I was actually looking at the wrong bit. My bad. Instead of 72, it should be 48 divided by 8. So you're giving 48 milligrams per dose. I apologize. I was reading the calculator in the wrong way. So it's actually 6 mLs. See, even I can make dosing errors too when I'm not actually writing everything out. But yeah, so that'd be 6 mLs twice daily. Sorry about that. Again, I would double check myself when I do this, but you know, it's a little early in the morning, so you have to forgive me if I make an error here or there. But let's look at another example here. Let's look at something that happens a lot, like in the ERs, where patients will come in with their parents and they say, "Oh, I gave this much Tylenol." You got to figure out, is that a correct dose? Are they giving enough? Are they giving too little? And they may be over or under treating the patient's fever, for instance. And so let's say here we have a parent that comes in to the urgent care, the ER, or whatever, and they have a 20-kilo child, and they've been giving them 2 teaspoons of acetaminophen 4 times a day for their fever. And you want to figure out, is that enough for that patient, or is it too much, right? So what I can do here is go ahead and figure out like what the normal dosing should be, and then compare that to what the patient's actually getting there, right? So what can I do here? Basically, we're going to see here that by starting off, we want to figure out what the patient's actually getting in the first place. And so we know they're getting 2 teaspoons of acetaminophen, and it only comes in as a suspension of 160 milligrams per 5 mLs, okay? Well, first off, we want to figure out, well, how much are they actually getting here? 2 teaspoons, if you recall, I said a teaspoon's 5 mLs. So 5 mLs, 2 of those, so 5 times 2, they're getting a total of 10 mLs of this suspension of acetaminophen, right? So 10 mLs. So first off, I want to figure out, well, how many milligrams is that? So I can take that 160 divided by 5. And so what you're going to see here is by converting it over into per ml amount, I know it's 32 milligrams per ml. I can then multiply that by the 10 mLs that the patient's been receiving. So the parent's giving them 320 milligrams 4 times a day. I need to figure out, like, well, is that an appropriate dose for that type of patient, right? Because I need to see if that's too much or too little. So what's the usual dose? Well, the usual is 15 milligrams per kilo. So I can then multiply that by the patient's weight to actually figure out what they should be getting. And so I can say 20 kilograms. I can multiply that by the 15 mg per kilo per dose. And so I see they should be getting 300 milligrams, right? So parents giving them 320, the patient's getting 300. Is that a clinically significant difference? Actually, not really. It's within 10%, so I don't really care that much about it. So yes, that parent is dosing that child appropriately, totally within the realm of normal dosing, right? So that's another way you can do it. That's sort of how you can go backwards and sort of double check the calculations that you're doing there, right? Okay. So another thing I want to show you guys here is about drug dosing calculations for fluids. This is something that you'll do frequently for pediatric patients, and so you should have some familiarity with. And it's good to know this early because you will be able to whip this out on your rotations, and you'll just kind of know it inherently. It's a nice leg up on other students out there who may not know this stuff, and you'll look pretty impressive in front of your preceptors. But typically for a fluid bolus for pediatric patients is 20 mLs per kilo. This is a good number to remember just for typical dosing for pediatric fluids for your patients, right? So 20 mLs per kilo for a fluid bolus. If you have someone who's dehydrated, they've been vomiting, or they've had a lot of diarrhea, and you want to replete that fluid, you give them a fluid bolus, 20 mLs per kilo, right? Or they're hypotensive, something like that. This is a good way to start out. But oftentimes what you're going to do is then convert the patients over into maintenance fluid. So assume you want to admit that patient to the hospital. You're going to put them on maintenance fluids because maybe that poor PO intake. And so you got to replace what they are naturally losing throughout the day. And so that's what maintenance IV fluids do. They replace what you would naturally be losing throughout the course of a day. To figure this out, I like to use what they call the 4-2-1 rule. 4-2-1 rule is going to be how we figure out the maintenance fluid rates in terms of mLs per hour. So how many mLs per hour should the patient get of, normal saline or D5NS or something like that. We'll talk about the different types of fluids later on, but I just want you to get the dosing down. So the 4-2-1 rule is broken down, and it's easier the more you practice with it. But basically, for the first 10 kilograms of a patient's weight, it's going to be 4 mLs per kilo per hour. Okay, up to a max of 40, right, for that first 10. So 10 times 4 is 40 mLs per hour. Then for the second 10 kilogram of a patient's weight, it's going to be 2 mLs per kilo per hour. Then you add that to that initial 40 mLs per hour that you had from the first step. And then after those two steps there, for every subsequent kilogram, you're going to add on 1 ml per kilo per hour. That sounds complicated, but let me show you what that means here. Basically, what you can see here is that let's say we have an 8 kilogram infant, right? In this case here, we're only going to be using the first part of the 4-2-1 rule because they're less than 10 kilos, right? So for their fluid bolus, I can do 20 mLs per kilo, and I can multiply that by 8 kilograms, and their fluid bolus is going to be 160 mLs, okay? Then their maintenance rate that I would follow that up with would be 8 kilograms times 4. They would be getting 32 mLs per hour, okay? That one, you only need the first step of the rule because they were not more than 10 kilograms. Let's say we have a 1,200 gram neonate. This gets a little more complicated because now you got to figure out what they are in kilograms. And if you recall how to switch over between different metric units, right, you're going to go ahead and convert that over from 1,200 grams to 1.2 kilograms, right? So again, you can review that online. There's places to look at, different unit conversions there, but 1,200 grams is 1.2 kilograms, okay? So now, again, I only have to use that first step of the 4-2-1 rule, but their fluid bolus would be 1.2 kilograms times 20. They're only going to get 24 mLs as a fluid bolus. It's very tiny. This is a very tiny unit. I actually had a unit yesterday that was like 0.5 kilograms, so they get even tinier than that. But 24 mLs, if you think about it, like an ounce of fluids is 30 mLs. A shot of alcohol is an ounce and a half. That's 45 mLs. So they're not even giving a shot glass worth of fluid here. So it's a very tiny amount, which is why you want to get this right, because if you give them too much, you can really screw things up, right? Anyway, so to get their maintenance rates, I would then take that 1.2 kilograms. I would multiply that by 4, right? And their maintenance rates is 4.8 mLs per hour, right? Pretty straightforward. Now, let's see if we had to use the rest of the steps of the 4-2-1 rule here. Let's say we have a 45 kilogram adolescent. Let's say we want to figure out what their fluid bolus is going to be. It's simple as 45 kilograms times 20 mLs per kilo. You get 900 mLs. If you rounded that up to a liter, I probably would not have too many issues with that, right? Pretty straightforward there. Now, let's do the 4-2-1 rule for this patient. So for the first 10 kilos of their weight, it's going to be 4 mLs per kilo per hour, right? So I go ahead and multiply that 4 times 10. So their first 10 kilos are going to get 40 mLs per hour, okay? Now I know that they have an additional 10 kilograms available. So for the second 10 kilograms, I'm going to do 2 mLs per kilo per hour. So 2 times 10 is going to be 20. So they're getting 40 mLs per hour plus this additional 20 mLs per hour. But I have 25 kilos left over, right? I've only used the first 20 kilograms of their weight with the 4-2-1 rule. What do I do with the rest of the 25? Well, it's just 1 ml per kilo per hour. So they have 25 kilos left. That means 25 mLs per hour. So it's 40 mLs per hour plus 20 mLs per hour. That's that first 20 kilograms plus the additional 25. So the total fluid amount they'd be getting per hour for their maintenance fluid would be 85 mLs per hour. Okay. Let's do a 100 kilogram teenager. What would I do for them, right? So a 100 kilogram teenager, say you got a football player comes in after an injury, comes in and multiply that by 20, get their fluid bolus. They might actually even get up to 2 liters of fluids. Most people probably just start with a liter and go from there, but you could do up to 2 liters, right? For their maintenance fluid rates, again, we're going to go through the same steps as the 45 kilogram adolescent. We're going to do that first 10 kilos, multiply it by 4. So you're going to get 40 mLs per hour plus the additional 20 mLs per hour based off the second 10 kilograms of their weight. But now we have 80 kilograms left over to work with, right? Now it's just 1 ml per kilo per hour for the 80. So that's 80 mLs per hour. So then I can take that 40 plus 20 plus 80. What do I get? 140. So their maintenance fluid rate would be 140 mLs per hour. So you can make up your own practice problems there and work it out with your fellow students. I would encourage you to do that, and you'll get a feel for how that all works out. So already spent too much time on this section. Finishing it up, that's that. So any questions on that, feel free to post them up while I pull up the week 4 PowerPoint here. Okay, so I don't see any questions and I don't see anything on the sticky board. So let us move forward. So we're going to talk about hemostasis and clot formation. So we're going to start off with our hematology drugs because I think it matches up with your medicine course. So kind of the first spot here, the first drugs we're going to get to. So let's talk about blood clotting a little bit. I like to go over some of the physiology first because I think that helps set us up to know what some of our drug targets are going to be and sort of what the normal function is, to see how drugs can interact with that. So what happens if you have like an injury to the vascular wall, right? So you have a blood vessel, there's an injury, there's a cut, something like that. That's where hemostasis comes into play because you want to make sure that you're not going to be bleeding through that to lose fluid and hemoglobin and all that stuff. So whenever you have this injury happen here, you're going to start to expose things like, collagen and some of these underlying things like von Willebrand factor here within the actual cells of the vascular endothelium, right? And so what this is going to do is start to trigger off a cascade that allows for the clot to form, right? Because you want to make sure that you can block that off to prevent any further bleeding from occurring. And so you're going to find that initially you're going to have some vasoconstriction. You're going to have a formation of a platelet plug, right? You can see that there. And then finally, you're going to have this fibrin protein web actually form here. So you can see sort of what happens when all that fibrin starts to kind of bring everything together. It's like a big sticky web holding all those platelets in place. And then now you have your clot. The steps of that get a little bit more complicated is when platelets find that collagen, because normally you're going to find the vascular endothelium is a pretty smooth sort of, you want your blood vessels to be nice and smooth, so nothing kind of sticks to them, so you're not clotting inappropriately, right? Whenever you do have that injury, though, that collagen is exposed, and then von Willebrand factor actually then holds those platelets on to the wall here, right? And then that is then going to lead to activation of the platelets, and I'll show you what that looks like in a little bit when the platelets become sticky. When they become sticky, they start to hold on to other platelets, and that forms the platelet plug, right? There's a couple things that causes this to occur. I'm not going to get into every one of these features here, but things like adenosine diphosphate can help to trigger the activation of the platelets. Things like serotonin can help to cause further vasoconstriction to help kind of lead to less bleeding from occurring by kind of closing up that hole there a little bit. And then things like thromboxane and other prostaglandins, which I'll talk about in more detail in here in a few minutes. Also, you're going to find that the platelets themselves will activate the clotting factors. So you kind of have your platelets starting to form this plug here, and then eventually you're going to have the, apologize for those little captions coming up there, but eventually you're going to have the clotting cascade occur as well. And we'll talk about the intrinsic and the extrinsic pathway here. But eventually what that is then going to form is fibrin. And remember, fibrin's that sticky web that holds everything in place there, and that forms that stable clot. So here's another picture of what this looks like. Again, here's an endothelial cell with some collagen underneath here. Normally this is very smooth. Nothing is going to be sticking to this. And then once you have an injury occurring here, this is where things like ADP is going to start to cause conformational shifts of the platelets. Normally the platelets are going to be in this sort of like globular sort of shape where they're very kind of bouncy and they bounce off one another, no problem. Eventually they become they change shape a little bit, and they have these little feet that hang off of them and appendages, and they stick to one another, right? So they get very sticky, forming that platelet plug, and then finally the fibrin comes in and stabilizes everything, okay? So how do we get some of those prostaglandins that we mentioned that help to activate the platelets here? And so basically with all of your cells, they are made up of a phospholipid bilayer here. And there's a lot of things like cholesterol and other hydrocarbons that are useful for producing things like hormones and other cellular mediators, right? One of which can actually come from this is called arachidonic acid. Arachidonic acid is really important. We're going to talk about it quite a bit in anything dealing with inflammation, whether it be asthma, whether it's rheumatoid arthritis, anything doing with inflammation, arachidonic acid comes up here, okay? Now, in one pathway, it can be acted on by this enzyme called lipoxygenase, and this is where it forms things like leukotrienes. This is important for asthma and COPD. We will come back to that at a later date. On the other side, and this is what I want to talk about today, is an enzyme called cyclooxygenase, which is sometimes abbreviated as COX or the COX enzyme. Cyclooxygenase will then convert this down into our prostaglandins. This is going to include things like prostacyclin, PGI2. This includes things like thromboxane, A2. All these ones have various actions. Some of them you'll find tend to be more antiplatelet aggregation. This is actually good if you had someone who may be prone to coronary vessel blockage. This is a good thing because it actually prevents platelets from aggregating. But more so when you have that injury occurring, this is where it becomes important to produce thromboxane because this actually encourages that vasoconstriction and platelet aggregation. These prostaglandins also have activity on things like the uterus and can control labor and things like that. So there's a wide range of activities here for the prostaglandins and what they do, but mainly I want to focus on this balance between thromboxane, which causes clots to occur, versus prostacyclin, PGI2, which is anti-platelet, anti-clot, because there needs to be a balance between these two, because if you have too much clotting occurring, that's where you start to cause emboli to form, that's where you cause blockages, you get ischemia. Not great, right? No matter where it's happening, whether the heart, the lungs, the brain, anywhere. You have to have a balance here. Now, as I mentioned, for platelets to activate, they respond to that exposed collagen, and they will then bind to that von Willebrand's factor. And once that occurs, then they're going to start to form these bridges here and with other platelets. The bridges that occur here are due to this 2B3A receptors here. This is what actually causes the cross-linking between the various platelets. I'll show you what that looks like in a moment. These only get expressed when you have exposure to things like thromboxane A2 and ADP. So these are really important to form in order to cause that conformational shift that occurs in the platelets to expose the 2B3A receptors. And that forms the bridge between platelets. Some other things that can form here include the P2Y1 and P2Y12 receptors. This is what ADP binds to. I only mention these because this will be important for some of our drugs here in just a few moments here. Now, when I talk about the clotting cascade, one of the big things that forms is called thrombin, and thrombin is actually really important. This is otherwise known as factor 2, and this is also going to help with platelet activation. You'll notice that clotting is sort of a positive feedback loop where it kind of propagates itself. So by forming more active platelets, you're going to get more clotting cascade kicked off. You're going to get more thrombin form, which causes more platelets to activate. And so it's this kind of cycle that allows for very quick clotting to occur. And then when you don't need any more, then it kind of peters out and it stops. Now, can that go too far? For sure. There are some people who are very prone to clotting, unfortunately, and that is just sometimes a genetic thing. Sometimes it could be related to meds. It could be related to a lot of different things here. So here is a picture of a platelet. And again, I want to show you some of the different things that can activate it or inhibit it, as the case may be here. And we're going to find that many of these are going to be our drug targets. Some of the big ones I want you to focus on are going to be where thromboxane A2 is working, where ADP is working here. We'll talk about thrombin a little bit later on. And then again here, notice this cross-linking, right? Fibrinogen is actually what's going to form the cross-link between these two receptors here. And we'll talk about fibrinogen a little bit later on as well. But once these bridges form, then they stick together. That's what actually forms those sticky platelets. And this will be another big drug target as well, as we'll talk about in just a few moments, okay? And here's what a normal before activated platelet would look like. And then this is what they look like afterwards. Notice how they have these little podocytes that kind of stick off of them, and they bind to one another, and they form a nice big sticky plug. And then they get all held in with that cement that is fibrin, right? So let's look at the other side of things. How do we get fibrin? Where do we get fibrinogen from? Well, a lot of that is going to be due to the clotting cascade, and this is where a lot of our clotting factors are actually going to be coming from. We'll talk about the extrinsic and the intrinsic pathway, and then there's a common pathway down here at the bottom. And there's a lot of factors here. I'm only going to focus on them where it's important for where our drugs are working. So do I care that you know the specific order here for all of these? Not really. I'll talk about the important ones though, and the ones that I talk about are probably going to be more important to look at in terms of like knowing for testing purposes, right? But the main point of all of this is to actually form factor 2, which is thrombin, which helps to convert fibrinogen over into fibrin. That's the main point here. Also note that a lot of this is going to be a positive feedback loop where thrombin can further activate more of these pathways here to kind of get the ball rolling here. So that way you form a lot of fibrin all at once to get that clot nice and secure there, right? Here's another picture of what that looks like. You can see here the extrinsic pathway versus the intrinsic pathway. Different medications will work on different points here, right? So we'll talk about how certain drugs work more on the extrinsic pathway, certain drugs work more on the intrinsic pathway. And sometimes we use them together to get more synergy to try to prevent clots from happening, right? Because frequently when we're intervening, it's for a patient who's having a clot that shouldn't be there, and we want to help to prevent that from getting any worse, right? So if you have someone like an ischemic stroke or an MI, or they have a pulmonary embolism or something like that, we're trying to prevent this from occurring. And that's mainly what we're going to talk about that in terms of our medications, is try to prevent clots. Your body's pretty good at causing clots on its own, almost too good in some cases, and that's where we got to try to prevent that, right? But again, it all comes down to this common pathway. And again, we're going to talk about things like factor 10 and then factor 2. These are going to be some of the big ones we'll talk about, and how they're forming thrombin, which is activated factor 2, and that converts fibrinogen to fibrin, and that's what actually forms that nice cement, that stickiness that really keeps all those platelets in place. That's what that fibrin is for. And then there's a lot of different factors here. The ones that I'll probably mention as being sort of the most important is going to be fibrinogen, which is, again, gets converted to fibrin. That's good to know. Prothrombin, which gets converted over to thrombin. That's an activated factor 2. So factor 2 is important to know there. Factor 7 we'll talk about. Factor 8. This is where you actually have like patients who are hemophilic. Or have hemophilia, can have factor 8 or 7 deficiency. So those are important. 9 and 10, and then to a lesser degree 11 and 12. But we'll talk about these as they come up and become important for our particular drugs here in a few moments. So just to note that extrinsic pathway is typically going to be kicked off by exposure to underlying collagen and things like that, and due to this what we call tissue factor. So if you have like an injury to the vessel that occurs exposing some of that tissue factor is what kicks this off. And so this becomes really important because factor 7 is where this gets activated. So factor 7 is really important for here. Factor 10, as we'll see, is going to be part of that common pathway that gets into dealing with like factor 5 and 2 and all of that. But again, the common pathway always starts with factor 10 here. So 7 is really important for the extrinsic pathway, and then it will kick off and then get down to the common pathway with factor 10. Note here, calcium is also really important too for helping to kick this off as well. So calcium is a really important thing to help blood clot. And in fact, in some cases where we don't want blood to clot, we actually try to get rid of calcium. So if I have a patient who's getting like hemodialysis, I'm taking blood out of the patient, running it through this series of tubes to try to filter out their blood. Actually, I try to bind up that calcium to prevent it from clotting off in the tubes there, because that obviously can be a bit of a problem. The intrinsic pathway is a little more complicated in terms of the different factors here. What I mainly want you to know is that this is going to be more so not with like external injury to the vessel, as more to do with trauma to the actual blood itself, where the blood gets exposed to like collagen. So this is more of like an internal kind of injury thing. Note though, if you have like a vessel that gets ruptured, extrinsic and intrinsic are going to be working at the same time. So it's not like an either or. Oftentimes it's a both, depending on the situation. But this is where you're going to see things like factor 12 and 11 and 9. Different drugs are going to work on this pathway as opposed to working on the extrinsic pathway. This will be more clear when I get into the specific drugs. I just want to make sure that we all have a pretty good idea of kind of what these pathways look like. You'll probably get this heavier in your medicine course or something like that for sure. So anyway, as I mentioned there, we'll find which drugs work on the intrinsic pathway versus the extrinsic, and then they finally get down to the common pathway. Some drugs will work more specifically here, as we'll see, and so that'll be really important to prevent the conversion of prothrombin to thrombin. If you can prevent that, then you're going to prevent a lot of that fibrin from being formed in the first place. Okay. Let's see. So one place where we get a lot of our factors actually being formed is going to be the liver. So the liver is really important for forming a lot of our clotting factors in the first place. And again, most of your clotting factors are just floating around the blood. They're inactivated. They're waiting for something to happen, like an injury, to actually activate them. That's where you get these pathways kicking off. But normally when they're formed in the liver, which is why if you have someone who actually has pretty significant liver injury, one of the big things you'll see with them is they bleed. They actually bleed quite a bit because they can't form their own clotting factors. And so you can see here, this is going to be another step. If I can prevent the factors from being formed in the first place, I can help to prevent the patient from having coagulation occurring there. So you'll actually find some drugs can actually work here to prevent the actual factors from being formed. That's where we're going to talk about warfarin a little bit later on. But just know the liver is an important spot there for producing a lot of those factors. Now, the body obviously has pretty good ways to cause clots to occur, but they actually have natural anticoagulants as well, which is good because you want to keep that balance to make sure that you're not going to have too much clotting occurring. You're not going to have patients develop PEs all the time when they really shouldn't. And so this is where we're going to see that normally the vessels themselves are pretty smooth, and they kind of are naturally going to be inhibiting things from activating platelet or clotting factors there. So for instance, a thrombomodulin combines the thrombin and inactivates it, right? Or some of the more important ones, which I'll talk about here, is called antithrombin 3. This is a really important enzyme that works along with heparin Heparin's the one of the things we're going to talk about a lot, that it's a natural thing that we produce that actually will help to inactivate clotting factors. So for instance, like 2, 9, 10, 11, and 12 are going to be inactivated with heparin working with thrombin. I'll get more into the specifics of that in just a few moments, but this picture is a pretty good example of that. But I'll show you this again later on. And then you have plasmin. Plasmin is going to be important for actually converting basically the fibrin into more soluble particles. So plasmin is actually going to be what kind of breaks down your clots once you don't need them anymore. Once the vessel's been, has been healed, then you don't need that fibrin sticking around. This is where plasmin comes in and can then degrade that. Okay, so these are the natural sort of anticoagulants your body produces anyway. So the drugs, right? We got the physiology down. Hopefully that's a review for you. Let's talk about the actual drugs and where they're going to be working at. So if I want to start to talk about the salicylates, aspirin, and the NSAIDs specifically here. So when I say salicylates, that's really referring to this, class of drugs that mainly is comprised of aspirin. That's going to be the main one you're going to run into here. Now, aspirin itself is otherwise known as acetyl salicylic acid, which is why it's abbreviated ASA if you ever see that. So patients on 81 milligrams of ASA daily, that's where that comes from. Now, I'm not going to talk about NSAIDs and salicylates in terms of their use for inflammation or for pain. I'm going to really be referring to their use as antiplatelet drugs, okay? Because we're talking about hematology, we're talking about clotting. This is where these become really important here. I'm sure most of you know that patients who have maybe a previous history of a myocardial infarction, they take a baby aspirin daily. You're like, well, why do they take a baby aspirin? They're an adult patient. I'll tell you why that is right now. So anyway, so aspirin is going to be something that is has been around for forever. You know, we get it from the willow tree, basically. You get it from the bark there. But now we have natural ways or synthetic ways to produce this. But basically, what this is going to be doing is it's going to be an irreversible inhibitor of platelets, and it's going to do that by blocking the activity of COX-1 and COX-2. Those are two different varieties of the same enzyme. They have a little bit of different actions, and I'll talk about that in a little more detail coming up here. But notice here it's an irreversible inhibitor. Once it binds to the cyclooxygenase within the platelets, it's going to be preventing that platelet from clotting pretty significantly. Now, again, is it going to block every single pathway for that? Well, no. We saw there's multiple ways. Like ADP can activate it. We're not blocking the 2B3A receptor. So there's different ways for this to occur, but it's pretty good. Pretty good at preventing those platelets from forming clots when they really shouldn't be. With for instance, like with the coronary vessel. But the irreversibility is really nice here. And so once it binds to that COX enzyme and it inactivates it, it takes like 7 to 10 days for new platelets to form to actually produce new cyclooxygenase. So you tend to find that when someone's been on aspirin for a while, they can stop taking it, and they have around 7 to 10 days left of activity for that because of its irreversibility. Okay, that's going to be a unique thing with aspirin that you don't really see with other NSAIDs, which is why we don't typically use other NSAIDs as antiplatelet drugs, as we'll see here in just a little bit. But again, notice here it's going to be inhibiting thromboxane A2, which is important because that helps to prevent the platelets from becoming activated. It will have some detrimental effects by inhibiting prostacyclin production, which we saw was antiplatelet previously, but we're not going to worry about this too much. It's typically going to be overpowered by this inhibition of formation of thromboxane A2, right? So remember, you have arachidonic acid being formed from the cell wall, and then if you prevent cyclooxygenase from working on it, you can't form thromboxane A2, you can't form prostacyclin, and that's what we're looking for. That's the thing that's going to prevent these platelets from becoming activated. And what you'll find is that you don't really need a whole lot of it due to the irreversibility of it. You tend to find that between taking 81 milligrams and 160 milligrams a day, you get pretty maximal platelet COX inhibition, which is all you need, right? So that's why you typically see patients taking like a baby aspirin every day to prevent, another MI from occurring, to reduce their risk for mortality. It's because that's all you really need to do, the irreversibility of the actions of aspirin on that cyclooxygenase. And actually taking higher doses than that tends to have more activity on PGI2, which we don't like because this actually has natural antiplatelet activity anyway. So stick between 81 and 160 a day. As I mentioned here, this is just one pathway to block the activation of the platelet. You have many more here, but by blocking off one of the major ones, it overall leads to things like decreased incidence of MI in patients who have a previous one, decreases in mortality, and it's cheap and easy to give. This is why we use it for most patients who have history of myocardial ischemia, right? And again, looking at this, you can see by blocking that arachidonic acid conversion, by blocking cyclooxygenase, this is what aspirin binds to and activates, you prevent the production of things like thromboxane A2. And this is the main activity we're looking for because it helps prevent that platelet aggregation from occurring, okay? That's what we're using aspirin for. Note here that it works on both COX-1 and COX-2 equally. We'll talk about NSAIDs later and their use for pain and to where we actually have some selectivity we can look for, but we're not too concerned with that right now. We're mainly focusing on the thromboxane activity that we see with blocking cyclooxygenase in those platelets there, okay? So what are the downsides of using salicylates? Well, you want to make sure that you're not using too much of it because you can't get too much of a good thing here. So again, typical dosing, you can see here between 81 milligrams to 325 milligrams, this is going to be where you get the main majority of your antiplatelet effects. What is a natural side effect of that? Well, bleeding can occur, right? We know bleeding is a risk. It's relatively low risk when you're using typical therapeutic dosages here. However, as you start to get up to higher doses, maybe where you're starting to use it for things like, antipyretic effects or analgesic effects, you can get more nausea, vomiting, you can still see a bleeding risk there. But much higher doses than that, you really want to be cautious with because patients tend to have really bad times with this when they get too much aspirin. I've seen many cases of this. And one of the big things you'll hear them talk about is they'll talk about kind of muffled hearing or tinnitus, right? Some people say tinnitus. I actually had a neighbor one time that was an audiologist, and I asked him, and he said tinnitus. I say tinnitus too. I figure trust the expert. But anyway, point being is that that's something you can see with patients. They'll talk about like muffled hearing or ringing in their ear, and that could be a sign they're getting too much aspirin there. Much higher than this, you can start to get to some really nasty effects here. I'm not going to get into today, but just know salicylates can be a pretty nasty overdose. You want to be really cautious with those. But again, when you're sticking in the typical dosing we're talking about here for antiplatelet effects, bleeding risk is, while low, can still occur, especially when you're mixing these with different medications. You're going to see here sometimes we combine different antiplatelet drugs together for synergy, and that's something you want to note there because as you combine more drugs together, your risk for bleeding is going to go up, as you might imagine. Okay, so where is this contraindicated? You want to be really careful with this with patients with bleeding disorders because this is going to exacerbate that. Pregnancy, we typically don't use it very often in pregnancy due to some risk there with the fetus that's developing, so we typically don't use that too often. The big thing you want to note here too is that kids who've had a recent viral disease, so like influenza or the chickenpox and maybe even COVID, I don't know if anyone's actually looked at this, when they're post-viral and say, for instance, they still have a fever, you're going to get them aspirin, they are at risk for developing something called Ray's syndrome. Okay, this is specifically for kids like less than 16 most often. And so you say, well, what is Ray's syndrome? Well, it's this fatty liver encephalopathy that can occur that can be quite fatal if not caught early and actually managed. So, kids 15 and under has about 50% mortality if not caught and managed early. The problem with it is that a lot of the effects of Ray's syndrome look similar to a viral injury, right, or a viral illness. So vomiting, lethargy, things like that. It may be difficult to determine that it's actually anything other than just the cold, right, or the influenza. So be very cautious anytime you hear a history of someone having a kid having a viral illness, giving them aspirin. Don't do it, right? Because this risk for Ray's syndrome is unacceptably high there. And what this leads into is developing significant liver injury. They can develop severe CNS toxicity and eventually lead to death. So don't use aspirin or other salicylates in kids in this sort of category here. So less than 16 with a viral illness. Okay, doesn't mean you can't use aspirin in kids. It just means you want to be really cautious, especially if they've been sick recently. Okay, now as I mentioned, aspirin is going to be an irreversible inhibitor, so its activity lasts like 7 to 10 days, which is why we like it in terms of the antiplatelet effects and preventing MI from occurring in high-risk patients. Right. Notice here, all 3 other NSAIDs you're going to run into, which I'm only mentioning briefly here, they're reversible inhibitors. So as soon as they're out of the system, their bleeding risk goes back down to 0 because they are reversible. Once they dissociate from the COX, they just go back to normal, right? Whereas aspirin irreversibly binds to that. The body has to make new platelets with new cyclooxygenase for it even to begin working again, okay? That's the thing you want to know with that. So the NSAIDs, we're not going to use for antiplatelet effects because they're only going to be temporary while they're in the system. But most side effects you're going to run into more commonly with NSAIDs and aspirin to some degree is going to be a lot of dyspepsia. You're going to get a lot of GERD, and there is a risk for having peptic ulcer disease, okay? And actually GI ulcers is one of the main things you're going to see with patients taking too much aspirin or too much NSAIDs over the course of, say weeks to months. It's low risk when you have patients taking like 81 milligrams of aspirin a day, but certainly if they're taking that with NSAIDs for pain or something like that, that's where you're going to run into problems here, because you can actually start to break down the protective barrier in the stomach and actually lead to ulcers forming. And so I'll talk more about that later in the GI section, but just know that's a big risk. And actually NSAIDs are probably, that in H. pylori, the number one reason why people get peptic ulcer disease, those two things there, okay? Anyway, so now we talked about inhibiting cyclooxygenase with aspirin. Now let's talk about another pathway to prevent our platelets from clotting, and that's going to be ADP receptor antagonists. If you recall, ADP was another thing that actually helped to activate those platelets during that cascade we were talking about. And typically this is through the P2Y1 and the P2Y12 receptor. By blocking both of these, which most of our ADP blockers will do, they will then prevent further activation of the platelet, right? And oftentimes what you'll see, especially with someone who has maybe coming in for like an NSTEMI or something like that, you'll actually be using an ADP blocker plus aspirin to get some synergy there, right? Sometimes by working through two different pathways, you get greater effects in trying to prevent a clot from occurring, like in a coronary vessel, for instance, okay? So again, you're going to find that by blocking both of these, you're going to be able to help prevent a lot of that cross-linking from occurring by preventing those GP 2B3A or glycoprotein 2B3A receptors from even being exposed in the first place, okay? So by preventing that, you can prevent some of that cross-linking occurring between the various platelets there, okay? It also interferes with von Willebrand factor, which we mentioned is kind of found in that underlying endothelial tissue that can then also bind and kind of anchor onto those platelets there. There are three main ADP receptor blockers we're going to find here, including clopidogrel, ticagrelor, and prasugrel. Now, note, remember on exams, I will put the brand name and the generic name, but I'll mostly be talking about them in terms of generics because when you go take the PANTS, that's what's going to be on there. So be aware of that, okay? Anyway, these are going to be not irreversible like aspirin, but this is why people will take it every single day. And you may actually notice that it takes a few days to get sort of maximal clinical effect as you get to steady state. So it's not uncommon that patients will actually get this as a loading dose first. And if you recall, loading doses help us to get to steady state quicker, kind of immediately, and then you follow up with those maintenance doses. So it's not uncommon to see that. And you'll see this a lot for patients who may be at like high risk for stroke, or maybe if they're going back for to the cath lab for like an NSTEMI or a STEMI, something like that. This is where you're going to see a lot of those ADP receptors being used. Or for like patients who can't take aspirin, this may be a good alternative. They have like an aspirin allergy or something like that. You can use this instead. Now, a lot of these things like clopidogrel tend to be a prodrug, meaning they have to be taken orally and then converted in the liver to the actual active form, right? So that's why I say hepatic activation. And typically we'll give it as a loading dose to get them to steady state, and then it's kind of working just as it should right away, which is nice. Obviously, bleeding risk is going to be the big thing that we worry about here, because again, preventing platelets from activating, right? Just like with aspirin, bleeding is a big risk. There is very small risk for things like neutropenia, so you do want to watch that like on your CBC. And there's something called thrombocytopenic thrombotic purpura, or TTP. This is something that has quite low risk. It used to be higher with some of the older ADP blockers, which we don't use anymore, but it's still a risk there. So this is something where you'd be looking at the platelet count. If it started to drop all of a sudden, you'd be really worried about this. So very rare though, so we don't worry too much about that. And again, nausea, vomiting, maybe some rash, pretty well tolerated. It's really the bleeding risk that you're going to be most sort of concerned with: bruising, bleeding, that sort of thing. Some of the newer ones we have include prasugrel and ticagrelor, and they actually have even stronger antiplatelet effects than clopidogrel. Clopidogrel was used for a long time because it was kind of the first kind of breakout drugs in this category, but now we have a few newer ones that are stronger at inhibiting platelets, but also the risk for bleeding is higher. Okay, so you kind of have to balance the pluses and the minuses there. You want good platelet inhibition, but the more platelet inhibition you have, the higher the risk for bleeding. Okay, so just know that's going to be kind of a double-edged sword there. And nowadays, most places are actually recommending prasugrel and ticagrelor over clopidogrel. So it just depends on what the hospital formulary is and things like that. Some other risks you can find with this include things like hypertension, which a lot of these patients with MIs and whatnot already have in the first place. So it could be a risk there. Hyperlipidemia, headaches. So those are some of the common side effects you're going to run into with prasugrel. Similarly with ticagrelor, this one, while it does not have is not a prodrug, it's active right away. It doesn't require the liver to be activated. Does have some active metabolites, meaning once the liver breaks ticagrelor down, there's some metabolites that actually still have good antiplatelet activity around, which helps to kind of extend out how long it's working for and how well it's going to be working in the long term. And so what you can see here is that it has stronger antiplatelet effects than clopidogrel, and so it's going to be bigger bleeding risk as opposed to clopidogrel, right? So major bleeding is a risk here for sure. You can also see things like increased uric acid, which may not be great for patients with gout, for instance, and actual dyspnea can occur here as well. So one thing to watch out for, notice they're having any trouble breathing, things like that, you may want to be on the lookout for, okay? So those are the ADP receptor blockers. So now we've blocked thromboxane A2 from working in the platelets. We've blocked 2B3, ADP. Now let's look at the actual bridge between different platelets, right? Let's go back and look at the actual 2B3A receptors that use fibrinogen to help bridge all these different platelets together to form that plug, right? And so we have a couple here. These are mainly going to be used in the hospital setting, whereas ADP receptor blockers and aspirin can be used on a daily basis in the outside world. These are going to be IV drugs we're giving in order to help prevent clotting during an actual event like an NSTEMI or something, or STEMI. These are used for patients going back to the cath lab, for instance, to try to prevent them from clotting while they're getting the catheterization being done, right? So first off here, we have something called epsiximab, otherwise known as Riapro. Epsiximab, and you notice here, it's a pretty short half-life, which is why we have to give it via continuous IV infusion in a lot of cases there. Now, one thing I want you to note with this is that anytime you see MAB at the end of a drug's name, that means monoclonal antibody, okay? This means it's actually an antibody that we have produced, us as people have produced, in order to target and neutralize something, right? It could be other antibodies. It could be snake venom, for instance. In this case here, this is an antibody targeting the 2B3A receptors. Once it binds to that, it then inactivates it, because once this antibody is stuck to it, then it can't bind to fibrinogen and it can't cause that bridge to occur, right? So pretty good at what it does, but it's going to be pretty expensive because of the fact that it requires a lot more engineering in order to produce an actual antibody, which is a protein, than something like aspirin, which is a pretty simple organic molecule, right? Also to note as well is anytime you're giving foreign proteins to a person, there always is going to be a risk that they could have a reaction to that, right? Just like you can have a reaction to blood products, you could have a reaction to any proteins being injected into a patient. So the risk for anaphylaxis is there. So you gotta be really cautious for that and look out for those signs and symptoms of anaphylaxis. So dropping of blood pressure, urticaria, dyspnea, airway swelling. Those are the things you want to watch out for, okay? So what we're going to do here is that typically when patients are undergoing angioplasty or they're going to the cath lab or something like that, we're using combinations of different drugs here. So maybe using aspirin and along with some other anticoagulants, things like heparin, which we'll talk about later, together in order to get even better antiplatelet effects here. So you're looking for a lot of synergy in these sort of acute sort of instances. So in this case here, bleeding obviously is the biggest risk. You can also see some risk for thrombocytopenia. And then as I mentioned, your body, while it may not get a reaction to epsiximab at the first time you give it, there is a chance the body could develop antibodies. So if they had to get a second dose of it or second round, they could be more likely to have an anaphylactic reaction. So that's something you want to be cautious with. Okay, so you can ask about, did they ever receive the drug Riapro or epsiximab before? So in the same category, but instead of using a specific protein here, now we have a drug called eptifibatide or integralin. And so this is going to be, again, used in combination with other drugs in order to, again, get good antiplatelet effects, prevent the clot, the actual platelets from forming that plug there. Usually used during, acute coronary syndromes, used in angioplasty, things like that. This one's less immunogenic because if you notice here, it's just a typical organic sort of molecule. It's not a big protein like you would see a big antibody like you saw with the epsiximab. So less immunogenicity, less risk for anaphylaxis, which is could be a good thing. Okay. And then finally, we have tirofiban. Again, this is a non-peptide. This one is renally eliminated, so you would want to watch out for that. If they don't have good renal function, you may find that you don't get rid of it as well, and that bleeding risk could elevate. So you want to be cautious with that. Obviously here, bleeding being the biggest problem, bradycardia, dizziness can also occur as well. So you do want to be cautious with that. All right. So those are the main sort of antiplatelet drugs we're going to see there. So again, three main mechanisms. You have your COX inhibitors with aspirin. You have your ADP blockers with things like clopidogrel, and now you have your 2B3A blockers, right? So limited number of drugs we've talked about so far, but remember to sort of categorize them into their little boxes of like, what's the mechanism? What are their purposes? What sort of side effects are they going to have? And so far, it's been pretty easy because most of them bleeding is the biggest risk, right? So again, if I had to say which one of these can cause bleeding, you'd be able to point out all of these as being some degree of risk, right? Because just of their nature of their mechanism of action, is just what they do, right? So now instead of focusing on the platelet, I want to shift gears a little bit and talk about the clotting cascade, right? I want to talk about the actual formation of converting fibrinogen over into fibrin that actually forms that sort of cement, that web that holds all those platelets in place. And so we want to start off with heparin here. Heparin is a natural product that we form, right? It's actually kind of a combination of a protein and sugar long molecule you can see here. It's usually between 200 to 300 monosaccharide units long. So it's a pretty long sort of sugar molecule here. And this will make more sense when I show you kind of a pictorial example of what this looks like. And basically, heparin, what it does is it's going to be binding along with the enzyme antithrombin 3. And so I'll show you a picture of this in a second here. But and when we talk about heparin, just like the natural heparin your body produces, this is what we call unfractionated heparin. This implies that there's a fractionated heparin, which we are going to talk about in a few moments here. But this is just natural, normal heparin. And we can actually give this exogenously too, right? So people form their own heparin, but I can give them extra heparin to help out and prevent clotting from occurring. And so what this does is that there's an enzyme called antithrombin 3, which if you recall previously is a natural anticoagulant sort of drug. Antithrombin 3 works to inactivate factors 2, 10, 9, 11, and 12. Now the main ones that I would focus on here for our purposes are 2 and 10. Those are going to be some of the really big players here because those are in the common pathway. It doesn't matter if you're clotting through the intrinsic or the extrinsic pathway, they all end up in the common. So these are going to be sort of the most bang for your buck is inhibiting factors 2 and 10. It's got some additional benefit because this 9, 11, and 12 are being affected, but these are only in the intrinsic pathway. These are going to be in the common pathway, 2 and 10. One thing to note. But basically, antithrombin 3 is pretty good, but it's kind of slow, right? So what does heparin do? It actually increases the activity of antithrombin 3 by like 1,000-fold, right? So huge additional benefit here to allow for antithrombin 3 to bind to and inactivate all these clotting factors, right? And notice here this little A, this means they're in the activated state. So it's trying to inhibit the activated clotting factors that are trying to clot right now, as opposed to when they're in their resting state and they're just floating around not really doing anything, which is good because you don't want to go and inactivate all your clotting factors because then you wouldn't have any left to actually cause clots to occur, right, when you actually need it. So anyway, once they are then inactivated, then they will then dissociate from them, the heparin's released, and they can go and then do the same thing all over again. So looking at what this looks like, you can see unfractionated heparin's a pretty long chain here. It can then bind with antithrombin 3, and then looking at, say, factors 2 and 10, for instance, here, you notice here that it facilitates the binding between these, right? So it facilitates the binding between antithrombin 3 and the clotting factor, and then once this occurs here, this is now inactivated, okay? So it's taking the activated clotting factor and then inactivating it. And again, as I mentioned, 2 and 10 are going to be sort of the big ones here from our standpoints as having the most bang for your buck, okay? So then getting into some other thing here, notice here that in order to get heparin, we actually used to pull it out of things like, porcine, which is pig intestine, or bovine lung. Nowadays, we have some more synthetic means of actually producing it, but it's kind of interesting to see sort of the original animal sources for some of these drugs here. But basically what we're going to do is that we can either give this for prevention of clots, or we can use this to treat active clots. So if you ever hear about thromboprophylaxis, or if you hear about like DVT prophylaxis or something like that, deep venous thrombosis prophylaxis, you can use it for that purpose. Or if the patient has an active clot, you can use it to try to prevent that clot from getting any bigger and actually help the breakdown process to occur here, right? So when you're using it for sort of preventative purposes, typically you're going to have to give this sub-Q. This cannot be given orally because it actually gets degraded in the GI tract and there's no bioavailability. So for you giving it for prophylaxis, you'll see a lot of sub-Q administration. If you're seeing this being used for treating an actual clot, this is where a lot of IV administration is being used here as well, right? So sometimes you ever see patients who are, say for instance, like on a really long plane ride, say across country or across the ocean, for instance, and they're sitting around for hours and they have all that venous stasis occurring. Sometimes they'll actually get heparin prophylactically to try to prevent a clot from occurring. Or if they're like in a hospital bed and they're laid up for weeks or months, we'll give them prophylactic heparin in order to prevent clots from occurring. Because anytime the blood is being very static and it's just kind of sitting there and the veins not moving around because you're not getting up and walking, that tends to cause clotting to occur when the blood's just kind of sitting there. But anyway, this is also good for pregnant patients, and because it doesn't actually cross into the breast milk and it's not going to get does not cross the placenta or anything like that. So pretty good for pregnant patients. You'll see that pretty often there. And just note, this is how we're going to be using it. Typically for treatment of actual clots, we're going to be using as a continuous IV infusion to try to keep the blood at a certain level to where it's not very likely to clot, but it's not so unlikely that you're going to be bleeding all over the place, right? You don't want to be bleeding like a stuck pig, as the saying goes. How do we monitor for that, right? And so one of the big things I want you to know here is whenever I mention monitoring parameters of specific lab tests, this is what you're going to be, this is one thing I definitely want you to know. And so, how do you measure to see if a patient is, properly anticoagulated, but not too anticoagulated such that the risk for bleeding becomes too high, right? So again, this is a double-edged sword, and this is one of those things where I talk about a narrow therapeutic index drug. This is a good example of that because, again, the therapeutic effect and the toxic effect are mediated through the same thing, the same process here. So you got to make sure you're getting just enough to keep the patient from forming any more clots or to prevent the clot that's there from getting any worse, and then not so much anticoagulation that they're going to just bleed out, right? Because again, that's not going to be good for them either. How do we do that? Well, we can use what we call the APTT, or the activated partial thromboplastin time. This is mainly going to be measuring the activity of the intrinsic pathway, right? So when I mentioned factors 9, 11, and 12, that's the intrinsic pathway, and this is how you monitor how well it's working. Now, typically, how we do this, we'd actually look to see what this time is, and this time is in seconds, right? And what we would do is take what a normal patient would be, that's our normal, and then we compare it to what their value is, and we're shooting for a ratio. We want this to take longer. It takes longer for the blood to clot, and that shows us that they're anticoagulated, right? And so typically you're shooting for a ratio of like 1.5 to 2.5 times longer for this patient who's getting heparin to clot than someone who is not being anticoagulated, okay? So that's how we monitor for this. For these, notice we didn't have any monitoring parameters specific for antiplatelet effects. Unfortunately, we don't have anything like that, but certainly for the anticoagulants, we do. And so this is what I want you to know from this slide specifically. And again, what are we going to use this for? Patients who have deep venous thrombosis, pulmonary embolism, MIs, all that good stuff. Anywhere you don't want a patient to get a clot, or if they have one and you don't want that to get any worse, this is where heparin is going to come into play, okay? So, as I mentioned, bleeding is going to be the biggest thing we worry about. Now, when I talk about reversal agents, this is another thing I want you to know as well. So, if I have you give you a test question, I say a patient's bleeding due to heparin, you need to know what the reversal agent is going to be. And there's only a few of these we'll talk about, so it's good to know these. In this case here, it's actually going to be a drug called protamine sulfate. You can use this to actually bind up the heparin and prevent it from working with that antithrombin 3, and that slows down its activity pretty significantly. So heparin overdoses, you'd give them protamine in order to treat that, right? The other big risk you're going to see with heparin, especially if patients have been getting it for like several days to a week or two, this is where you can run into what we call HIT, or heparin-induced thrombocytopenia. Okay, it's fairly low risk, but it's sort of a type of reaction that the body can have, where basically your body will start to develop antibodies to heparin and another product called platelet factor 4. This antibody is kind of interesting because what it actually does is it causes platelets to activate. And so when they're activated, they then start to form these little microclots all over the place. And when you actually measure the CBC, you'll notice they had thrombocytopenia. And it's not because the platelets like disappeared, it's just they're all being used up in these little clots all over the place. So it's kind of kind of oxymoronic that you're giving an anticoagulant and there's this risk for having this reaction that actually causes thrombosis to occur, right? So it's a risk, it's a low risk, but this is why you have to monitor things like the CBC to make sure that the platelets don't start to drop precipitously, which could be a sign that HIT is actually occurring here. And then we actually have to discontinue immediately. They can never get heparin again because the reaction can come back. And then we actually have to switch them over to some alternative drugs, which some of these I'll talk about here in just a few moments. So be cautious with that. Know it's low risk, but know it can occur and know what to do about it. Okay. So heparin's all well and good, and it's what we had for a good long time, but now we can start to get into some alternatives. And so now we get into the first one I'm going to talk about is our low molecular weight heparins. So if you ever hear the term fractionated heparin, this is what it's referring to, right? So basically, what if you took that really long heparin molecule and you started to chop it up into smaller pieces? You'll actually find there's some interesting changes in activity here. And so now we have a smaller sort of monosaccharide unit sort of length molecule here, and it's going to change how it works a little bit. Okay. There's a few drugs that fit into this category of low molecular weight heparin. The only one I'm going to mention here is enoxaparin or Lovenox, because clinically this is the only one I've ever seen used, and most people are pretty comfortable and familiar with enoxaparin. So this is the one I'm going to mention here. How does it work? Well, it works actually very similar to heparin. It works with antithrombin 3, but because it's a shorter molecule, what's interesting is it actually has preferential effects on factor 10A and less 2A, right? So you talk about driving, you talk about keeping your hands at 10 and 2. Heparin is all about keeping your hands at 10 and 2. It works very much on a 1-to-1 sort of ratio between these two here. Low molecular weight heparins are going to preferentially bind to and inactivate factor 10A. And it makes kind of sense if you look at a low molecular weight heparin here, which is a shorter molecule. It can still facilitate the binding here between factor 10 antithrombin 3 pretty well here. But factor 2A is just a little too big. You're going to find that it does not facilitate this as well. So low molecular weight heparins, enoxaparin, really good for working on factor 10A, not so much on 2A. It's a little bit of activity, but pretty minimal. So what's the benefit of that? Well, the nice thing about low molecular weight heparins, they have a longer half-life. So instead of having to give a continuous infusion on with heparin, I can actually give this as Q12 hour dosing. Just give you a sub-Q injection, Q12 hours, and they're going to keep the patient pretty well anticoagulated. So that's one of the big benefits. The other thing too is that as opposed to heparin, which can be affected by things like renal failure, have to watch the renal function, this is going to be less affected, although you do want to be cautious and make sure you're kind of dose adjusting based off of that. So for instance, if I have someone has like pretty significant renal dysfunction, I might have to give them only 1 dose a day instead of 2, for instance, or lower the dose or something like that. So you do want to be cautious there. And in terms of monitoring, what we can do is instead of looking at the APTT, low molecular weight heparins really won't affect that so much. And that's mainly because it's mainly affecting factor 10 and not really affecting like 9 and 11 and 12 and 2 so much. So you'll notice that you can give a patient Lovenox and their APTT may stay normal, or it really won't reflect how anticoagulated the patient is. And so what we can do is another lab test called the anti-factor 10A assay. So an anti-factor 10A is specifically measuring factor 10 activity, which is what enoxaparin is working on. And so we can do this in kids, we do this in patients with renal failure, or if you have like someone who's in the extremes of weight, either really obese or really emaciated, for instance, that's where we use an anti-10A assay to see how anticoagulated they are, okay? Now, note here that there's going to be a little less bleeding risk in heparin, which can be a benefit, and it still has a risk to cause HIT, but it's lower than heparin. Note here that if a patient has a history of HIT, you do not want to give them Lovenox because there is a risk of cross-reactivity there, so you would not want to re-challenge them. There's some alternatives I'll talk about you can use instead. So what if you took that low molecular weight heparin and then shortened it up even shorter? This is where you get into fondaparinux or a Rixtra. This has only activity on factor 10A, has no 2A activity, right? And in general, the reason why we like low molecular weight heparins is because they don't require as much monitoring on a routine basis as you do with heparin. Heparin, you got to monitor these APTTs all the time. For the most part, you can give a fixed dose of enoxaparin to a patient. I don't have to think about it, as long as I don't have renal dysfunction or any of the other stuff I mentioned. On the other hand, though, for fondaparinux, that has very similar in terms of like its monitoring. Note here that in order to monitor its effects, you would need to get a factor 10A level, anti-10A level, to see how well it's working. The benefit, though, with this one in particular is that it is has a very low incidence of HIT. And in fact, someone who has a history of HIT with heparin or with enoxaparin, they're fairly safe to get a Rixtra. So that can be an alternative if they've had that in the past. So just one thing to note with that. And again, this can be used for, clot prevention. You can use this, for instance, if someone has like a history of like hip surgery or they just had a knee replacement. Typically, patients will get put onto an anticoagulant afterwards to prevent a clot from forming, because typically patients are laid up in bed and they're not moving around as much right away as they might be otherwise. So this is where you can see a lot of use of Lovenox and Fondaparinux in these type of patients here. It's for clot prevention after surgery. So, and notice here too, with low molecular weight heparins and Fondaparinux, no good reversal agents. Sometimes we can use protamine for enoxaparin, but it's not super common as the other one. So just one thing to note with those. Now, instead of just fixating on factor 10A, what if we switched over and then worked on factor 2A instead? And so this is where you get our direct thrombin inhibitors. And so this is actually kind of interesting. These are based off of a product called Hirudin, which is the natural anticoagulant that leeches produce. So if you ever heard of like old-timey patients being treated with leeches for like bloodletting, this is why those patients will bleed, is because the leeches produce Hirudin, which will block factor 2A and cause the patient to bleed. I'm hitting the mic there. So we have 3 drugs in this category. We have lepirudin, bivalirudin, and then argatroban. Note here that these are the typical drugs. So if a patient has a history of HIT, you would then switch them over to this because there's no risk for HIT with these patients, because it's so structurally different from heparin as opposed to what you see with like, your enoxaparins and things like that. And so basically we would treat these patients who have HIT with these drugs in order to keep them anticoagulated, prevent any clots from occurring as a result of HIT, and then eventually we can transition them over to something else, right? If a patient could not receive heparin, there may be some cases where you'd want to use these as an alternative. Note that in terms of monitoring, you're using APTT again, right? So we saw that with heparin, you can use APTT. Direct thrombin inhibitors, you can use APTT. For Lovenox and for Fondaparinux, you have to use anti-10A levels. Okay, so the monitoring is a little different between these. You want to watch out for that. Okay, in terms of their excretion, it's mostly renal for bivalirudin and lepirudin. If you had someone who had poor renal poor renal function, this is where you might want to use something like argatroban as an alternative. So one thing to note there. Okay, so those are the main sort of like IV parenteral anticoagulants you're going to be talking about there. Notice we've talked about antiplatelet drugs. Then we switched over and talked about heparin, direct thrombin inhibitors. Those are anticoagulant drugs. Those are mostly the IV ones that we've talked about so far. Now we're switching over. And what if you had to have a patient who was on anticoagulation for a long term, right? So preventing activation of clotting factors for the long term on an oral basis. This is where we get into warfarin. And warfarin has been around for a really long time. It's actually, we use it as rat poison. We use kind of warfarin derivatives as a rat poison. If you're curious where the name comes from, or if you want to wow your friends, it comes from it's abbreviation of Wisconsin Alumni Research Foundation, which is where they actually found University of Wisconsin. I guess they found it there. And since then we've used it for a number of different things. We've used it mostly as an anticoagulant, but as I mentioned, you still can find some products that are similar to warfarin that are used as a rodenticide or as rat poison, essentially. And you're like, well, why would they give rat poison to your patients? Well, because it's a pretty good anticoagulant, as it turns out. Now, this works as kind of a very novel mechanism as compared to the drugs we've looked at so far that block activated clotting factors. This actually prevents the formation of clotting factors, and it does so by preventing the activity of vitamin K. No, this is not potassium, it's vitamin K. So the vitamin K that you normally get through your diet is used in the liver for this recycling process to form new clotting factors. And so the things I want you to know here is it affects 2, 7, 9, and 10. So what do you notice about this? Well, it's going to be affecting that common pathway of 2 and 10, and it affects factor 7, right? That's going to be big in the extrinsic pathway there. Also can affect things like protein CNS, which I'll mention here in just a moment. Basically, by preventing the recycling of vitamin K, you prevent the formation of new clotting factors, right? So this won't do anything to an already active clot, because it doesn't do anything to factors that are already floating around the blood. This just prevents clots from forming by preventing new clotting factors from being made. So it's one of the big differences you're going to see there. So normally you're going to find that when patients are taking this routinely, it takes a few days for the drug to really kick in. There's a delay in onset. And you're like, well, why is that? Well, it's because of the fact that your natural factors have their own half-life. It takes a while for them to be depleted from the body. You're just stopping the production with warfarin, right? Or Coumadin is a brand name. And so what you can see here is that actually early on, you actually end up depleting the body of protein C most quickly because it's a very short half-life. You actually end up finding that initially you can actually have a prothrombotic sort of thing there. So sometimes what we'll do for patients who are high risk for having a clot forming, we'll actually have them on something like heparin for a period of time. We'll start them on warfarin at the same time, so on heparin and warfarin, and then once they get up to an appropriate level of the warfarin, then we discontinue the heparin because it helps to prevent that procoagulable sort of stage there during the first 24 to 48 hours. It's called bridge therapy. If you hear that, it's where we're bridging from heparin to warfarin. So they're on both at the same time, which you think might lead to too much bleeding, but it's actually because you want to prevent the warfarin from causing a clot in the first place. So it's really for high-risk patients. But and even giving a loading dose doesn't really do anything to get around this. It just takes a few days for your body to deplete the factors that are already floating around, okay? So again, this is an oral drug. It was used for decades and decades because it still is used because it's pretty good bioavailability. It's oral. It's an anticoagulant. It prevents clots. We use it a lot for patients, for instance, who have like AFib. The atria are not really working all that well. You can find that they can have a tendency to cause clots, which can then lead to stroke. And so this is where the mainstay of its use is going to be. Or for patients who have like a previous like PE or something, they need to go home and be on anticoagulation for a few months. This is where warfarin comes into play here. Okay. There's going to be some downsides to it, which is why I'm going to spend a little bit more time on this. One, it's highly bound to albumin, which means that other drugs can come along and kick it off of the protein, which can lead to too much warfarin activity, which can lead to bleeding, as you might imagine. It's also metabolized by several CYP enzymes, and two of the ones I want you to focus on most is 2C9, which you actually find is going to be important because if you inhibit CYP2C9, that can lead to really increased effects of the warfarin because you have higher levels, and that's leading to more clotting factors being prevented from working or being formed. And then 3A4, right? We talked about 3A4 being really important here. So these are the two main ones I want you to focus on. That if you inhibit these enzymes, that's going to lead to warfarin levels to rise and leads to greater bleeding risk. If I were to have an inducer on board that upregulates these enzymes here, you're going to find that the warfarin levels will decrease, and that puts your patient at risk for clotting, okay? Another thing here, it's going to be contraindicated in pregnancy, so that's why most patients who are pregnant, if they're high risk for clotting, we put them on heparin typically instead of something like warfarin. So big things to know here. What are some things that are going to decrease the actions of warfarin, and what are some things that are going to increase the action? This is what you want to know. So things will decrease the action. If I have patients getting more vitamin K coming in through their diet, this is going to lead to a decreased activity of warfarin, right? Because again, warfarin works on the recycling of vitamin K that normally occurs there. By infusing the body with more vitamin K, that will decrease the activity of the warfarin. It takes time for the warfarin to then work on that new vitamin K that's now coming into the system. This is why patients with a high vitamin K intake in their diet actually can drop their the lab test we're going to look at INR. It's actually can drop their INR back down to normal levels if they get too much. What are some things with high vitamin K levels? Well, it's going to be things like green leafy vegetables for the most part. So things like spinach and collard greens and all those nice green leafy vegetables you probably hated as a kid. They actually have a lot of vitamin K. But even like oils like canola oil, mayonnaise, things like that can really drop someone's INR back down to normal if they're getting too much of it. We can dose around that, but it's important that patients keep a consistent level of vitamin K in their diet. They don't want them to go from like an all spinach diet to no spinach from week to week, because that's really going to monkey around with how well their warfarin is working. Okay, so more vitamin K means warfarin is going to work less effectively because now it has to block all that new vitamin K that's coming in. Okay, things are going to increase the actions of warfarin to make it more likely to cause bleeding to occur. Includes if you inhibit CYP2C9, that's a really big one. Right, 3A4 to a lesser degree, but 2C9 for sure. If they have a protein binding interaction, meaning something else kicks albumin, warfarin off of the albumin, meaning has a higher free fraction that can work. Anything that decreases vitamin K intake. So if I drop my vitamin K intake because I change my diet, that can definitely increase the activity of warfarin. Or for instance, if I get rid of the gut bacteria, which is actually a really important source of vitamin K, that can actually lead to, how do you get rid of your gut flora? Well, antibiotics. You can actually see an interaction where if someone is on warfarin and they get sick, they can actually end up finding the antibiotics will drop the vitamin K that they're intaking or absorbing, and that can lead to increased INR, increased risk for bleeding. So you gotta watch out for that. Liver dysfunction. As I mentioned, lower liver function means you're not producing factors, which means you're more at risk for bleeding as a result of that. And then the elderly tend to be at higher risk for bleeding from this. So I mentioned INR. How do you actually measure that? Well, it's because we're mainly working through the extrinsic pathway, we're using the prothrombin time. So we mentioned with warfarin, with heparin, you're using APTT. Here with warfarin, you're using PT and then something called INR, which stands for the International Normalized Ratio. Basically, labs can vary in terms of how they measure PT from lab to lab. So the INR is sort of a standardized value that we can use in order to compare apples to apples, so to speak. And so when you hear PT INR, usually the INR is what we really care about here. And this is a ratio between what a normal patient would be versus where your patient is at, right? And so target INR values are really important. Something I want you to know here is that for most patients, you're shooting for an INR of 2 to 3, meaning the blood is taking 2 to 3 times as long as it would a typical patient would in order for that clot to form, that blood to clot. So 2 to 3 for the majority of patients. Sometimes for patients who are really at risk for clotting, so for instance, if they have like a mechanical heart valve, you go a little higher, 2.5 to 3.5, okay? But 95% of patients on warfarin, they're going to be between 2 and 3. So something to know there. Now, again, as I mentioned, if they have warfarin resistance or mechanical heart valve, that's where you got to shoot for those higher levels there. Okay. Another thing to note too is that actually some patients may have different. This is where pharmacogenetics come into play. They may actually have a polymorphism that makes it to where their 2C9 is less effective, and that actually leads to increased warfarin sensitivity, meaning they're going to require lower doses to get proper anticoagulation because they don't have so much 2C9 there, meaning they're going to have higher warfarin levels than someone that had properly functioning 2C9. So sometimes you got to be cautious there. You'll find different patients, some will be really resistant to warfarin. I have to give them really big doses, whether due to diet or genetics, and some patients have to give them very tiny doses to get the effect I'm looking for because they're so sensitive to it. As I mentioned, bleeding is the biggest risk here. So you want to know what your signs and symptoms are. Gum bleeding, hematemesis, if they have dark, tarry stools, all those things you want to be watching out for. Sudden changes in mental status, especially if they fall and hit their head or something. Those are things you want to watch out for. It's fairly low risk for major bleeding with an INR between 2 and 3.5. It's when they start to get out of range is where things can increase their risk pretty significantly. And again, here's another case where I want you to know the reversal agent. Here it's going to be vitamin K. I can give them vitamin K to have them start to produce new clotting factors. But that takes time, right? And so if I had someone who actually was having like a hemorrhagic stroke as a result of too much warfarin activity, say their INR comes back into 7, what I can do instead of giving them just vitamin K, I'm going to give that to them for sure, but it takes time for the liver to then produce new clotting factors. What I can also do is give them fresh frozen plasma. Okay, by giving them FFP, that contains clotting factors, and so that can replace what the patient is missing. So for serious bleeding, hemorrhagic stroke, abdominal bleeding, something like that, I'm giving FFP plus vitamin K. For patients who are not having significant bleeding, I can just give vitamin K and stop the warfarin, obviously, and then that will allow for new clotting factors to form there. Okay. Other things to watch out for include birth defects, which is why we don't give it to pregnant patients, and then you can see some skin necrosis that occurs over time, but is fairly low risk. So we use warfarin for like decades, right? That's just what we use for a majority of patients. It was a pain in the butt because you had to, have the patients come in, get their INR checked every couple of weeks, and it was just a big hassle. So instead, now what we have are going to be what we call the NOACs or the DOACs. NOAC means novel oral anticoagulants. DOACs means direct oral anticoagulants, either nomenclature I don't really care about, but it's an alternative because, as I mentioned, warfarin is effective but highly diet dependent and required a lot of monitoring and had so many drug interactions that could occur. Benefit, though, is easily reversible. I can give them vitamin K, FFP, boom, they're going to be back to normal baseline coagulation. Well, we want some alternatives, though, because we need some different ones that can require a lot less monitoring for your patient who doesn't want to come in all the time. It's not going to be diet dependent. And so this is where we have our newer drugs. So we have 3 here I will talk about, including dabigatran, rivaroxaban, and then apixaban. And so what these do is instead of working on the production of clotting factors like warfarin does, these actually work on direct thrombin inhibition. So similar to what we saw with things like bivalirudin and leparudin, these work on factor 2 specifically. With the dabigatran I'm talking about here specifically, is work on factor 2. And again, by blocking factor 2, that prevents a lot of that recycling that occurs, that a positive feedback loop. So you kind of, as a secondary benefit, have less activation of things like 5, 8, 9, or 11 and 13 there. But the main thing here, just know that it directly inhibits thrombin factor 2. And so we use this for, prevention of DVTs or actual treatment of DVTs, PEs, things like that. But there's no routine monitoring. There's no routine effect on factor 2 on the APTT. We just don't know any good correlation there, so we don't really worry about it. So that's great and all, but what if a patient's bleeding? Like, what do you do about it? Well, nowadays we have a newer agent here called idarucizumab. Again, these monoclonal antibodies are always difficult to say. This is called Praxbind, and this is a monoclonal antibody designed to bind to dabigatran specifically. And again, any hospital you go to is going to have vitamin K. They're going to have FFP. Not every place is going to necessarily carry this monoclonal antibody. So again, reversing the bleeding risk with dabigatran can be difficult depending on the situation there. So just know that it's easier from a monitoring standpoint, not diet dependent. There's no routine monitoring for it, but the bleeding reversal may be more difficult. It doesn't respond to FFP, doesn't respond because I can give FFP to these patients, but it's just going to then block that factor 2 that I just gave them. So it doesn't do a whole lot of good. So, dabigatran's a factor 2 inhibitor. Instead, now switching over to like rivaroxaban and apixaban, we have actual direct 10A inhibitor. So you can think about this being very similar to fondaparinux in terms of it having activity just on factor 10A. Similar indications, just like you would see with warfarin, like you would see with dabigatran. Note here that the bleeding can be reversed with something called a prothrombin complex concentrate. So it's basically just really concentrated form of things like prothrombin and some other clotting factors. But again, whether a hospital carries that or not may be questionable. Who knows if they're going to reliably carry it, especially if you're out like working in the middle of nowhere, for instance. But pretty good. No monitoring, no diet issues there to see. No big drug interactions unless you're using it with other anticoagulants, for instance. But pretty handy there. And then apixaban, pretty similar. One thing to note though, with this one with the apixaban is it is metabolized by CYP3A4, and meaning if you have an inhibitor of 3A4 on board, you're going to find that it will lead to elevated levels and bigger risk for bleeding with that. So you do want to be cautious there. Okay, I think the last section here I'll mention is the fibrinolytic. So what do you do if you have a clot that's already formed? You have all the platelets plugging in it and it's being held into place with all that fibrin. Well, I can lyse the fibrin. So I apologize if I go a few minutes over, but I want to make sure I cover everything. So we use our fibrinolytics, right? Fibrinolytics are basically, say we go through this whole clotting cascade here, we get down to the stable fibrin. Well, I need something that can then break that down once that clot is no longer needed. And this is where plasmin comes into play. Plasminogen is converted to plasmin, and one of the big things we're going to talk about here is a product called TPA, or tissue plasminogen activator. It will then cause this to occur. Once plasmin is formed, it will then break down fibrin. So if I had a patient who had like an MI, for instance, or they were having a ischemic stroke due to a clot, I can give them something that activates plasmin, and that will then break down that clot. So these are what are referred to as our clot busters, for instance. And so using that, they're going to be able to go and then cause that conversion from plasminogen to plasmin. Typically, this is helpful by using something called tissue plasminogen activator, which I'll mention TPA here in just a minute. And it will lyse down a lot of these products here. So factor 2, fibrin, fibrinogen, very helpful at breaking those clots. But as you might imagine, very likely to cause bleeding. That's going to be the biggest risk here. Like I mentioned with probably all the other drugs so far, but yeah, bleeding for sure. Allergic reactions are pretty common to many of the fibrinolytics we're going to mention here. Anaphylactic reaction is possible. Many of them are protein based, right? So again, these are all going to be IV products here as well. And then risk for ventricular arrhythmias additionally. So not only do you have bleeding risk, but now you also have a risk for having dysrhythmia, which can also kill the patient. So got to be cautious here. Know the contraindications to getting fibrinolytics, because these are going to be sort of your big things to watch out for. If a patient has one of these, you don't want to go ahead and give it, right? Because they are too big a risk for having serious bleeding here. So things like surgery within the past 10 days, if they've had serious GI bleeding within 3 months, if they have history of hypertension, meaning they have uncontrolled hypertension, like their diastolic is greater than 110. Note here that's diastolic, not systolic. So it's pretty elevated diastolic pressures there. Previous cerebrovascular accidents, or if they have an active process like a tumor, aortic dissection. STK is called streptokinase. Don't worry about this one so much because we don't use too much streptokinase anymore. But they have a previous allergic reaction, don't obviously give it again. And then pregnancy. These are the big things you want to know. If a patient has one of these, do not administer the fibrinolytic, right? There might be a question on the test that says, here's your type of patient, and they have a history of peptic ulcer disease with a GI bleed 2 months ago. And you say, don't give a fibrinolytic, right? You have to be able to recognize that. So the main ones you're going to see here include alteplase, reteplase, and then tenecteplase. Don't really worry about where they're produced at. Just know that these are all synthetically produced proteins that we're administering, which is why they have that risk for anaphylaxis associated with it, right? All of these are going to be pretty expensive, though, just because anytime you're producing proteins synthetically, they're expensive. That's just how it is. The most common one you're going to run into, though, I will tell you far and away, is going to be alteplase or activase. This is TPA. This is recombinant tissue plasminogen activator giving. So if you ever hear someone say give them TPA for their PE or the MI or ischemic stroke, whatever, alteplase is probably what they're talking about there. Okay. More often than not, though, what you can also see is if you have like a patient with a line that's placed for like a long term, whether it be a sub-Q port or they're in the hospital for a while and they have a line that's in place for a while, that has a tendency to get clotted off, right? So if blood is static there within the line, there's a risk you can have it actually clot off and you can lose that line potentially. What we can do instead is that normally, nurses will keep the line filled with heparin, for instance, because that actually helps prevent any clotting from occurring. But what they can do instead, if it has now been blocked off due to a clot, is actually give TPA, and that can actually be used to break up that clot that's in the line itself and allow for patency to return, which is good because you don't have to give a new line if you don't have to. It means resticking the patient, or if it's like a central line, that's a whole surgical procedure you have to do at the bedside, but it's still a procedure. So again, bleeding risk, know the contraindications. Those are the big things with those ones. And that's it. That's it for the hematology section. Mainly focusing on the anticoagulants, the antiplatelet drugs that we use most commonly for prevention of clots, for treatment of clots, all that good stuff. Whether it be stroke, MI, PE, DVT, all those things. Kind of know how we're using these drugs. Know how we would synergize them together by using different mechanisms that are complementary, things like that. So for instance, would it make sense to use something like clopidogrel plus prasugrel? Well, no, that wouldn't make sense because they use the same mechanism. But what about aspirin plus ticagrelor? That would make sense because they're doing two different mechanisms at that point there. They'd be synergistic with one another. But what questions do you all have for this now that I've talked up a storm? That's generally how most of the drug lectures going forward are going to go, is we'll kind of go over a topic, talk about the normal physiology, and then get into the different drugs that affect those different targets, as we kind of saw here today. Any questions at all? The test is next week, so if you have any questions, I recommend getting them out now. Otherwise, you'll have to email me and respond to you. Can't tell if you guys are not super interactive due to it being 8 o'clock in the morning when we start this and the coffee hasn't kicked in yet, or something else. I'm going to assume that it's not me, because obviously I would never bore you guys to sleep. I mean, I know 28 viewers are there, but it doesn't mean you're not asleep in front of your keyboard, so who could say? Any questions? Well, if not, you are all free to go. I'll stick around for another few minutes or so to see if anyone else has any questions, but if not, I will see you all next week. In your exam, I think, will be next Wednesday. So I guess if you have any questions by then, you'll have another opportunity to ask questions, but we're going to keep moving on with, we're still going to have class Tuesday. So you'll do class Tuesday. I'm going to keep moving on with the lecture. So next Tuesday's lecture is not going to be in the exam. The exam material has ended today. And then you'll have the exam on Wednesday. So otherwise, I hope you guys have a great week. See, can you please explain the bolus and maintenance calculation again? Yeah, for sure. So let's do, I just post a sticky note up here. So remember, so if you're doing a bolus of fluid, so a patient, I've got to show you the right screen. That would probably help, right? So let's say you're doing a bolus of fluids. You have a patient comes in and they are hypotensive, or they've been vomiting, and you want to give them some fluids to replace what they're missing. That's where you do a fluid bolus, right? So fluid bolus is used there for those purposes of repleting what they're sort of missing at that point. And so that's going to be 20 mLs per kilogram, right? So just as like a single dose. There's some cases you give less, like if they have renal dysfunction or something, but for most patients, 9 times out of 10, you're going to give a 20 ml per kilo bolus there. And then following that up, right? So say like your patient's in the ER and you give them a fluid bolus, they feel a little better, but they can't really take anything orally. They can't really tolerate PO fluids. That's where you're going to get into your maintenance fluids, right? You have to give them something IV to sort of replace what they naturally lose throughout the day just due to urination and insensible losses and things like that. So you have to have your maintenance fluids, right? Maintenance fluids are going to be in mLs per hour, right? Because you're giving a continuous infusion of fluid, so it's mLs per hour there, right? So in that case there, what we can do is do that 4 to, not $4 to 1 rule in order to calculate how much fluid they should be getting every hour throughout that day to replace what they would naturally be losing anyway, right? So if you ever hear someone say like start them off at 1 times maintenance or 1.5 times maintenance, 2 times maintenance, half maintenance, this is what they're referring to. This is your baseline number you're using, and then you can kind of modify it based off of that. So I could, give a patient a fluid bolus, start them off on maintenance fluids, but they still look a little dehydrated. I can maybe start them off on 1.5 or 2 times maintenance in order to, again, get that fluid into the patient a little bit faster there, right? That's when we can do it. In terms of how to calculate that, though, how do you figure that out? Well, again, it's based off that 4-2-1 rule, and you could even apply this to adult patients, right? Not just pediatrics. It can be handy for anyone. But basically, as I said, for that first 10 kilograms, it's going to be that 4 mLs per kilo. Oops, if I could type. Per hour here, right? So for the first 10 kilograms, meaning up to 10 kilograms, you just do 4 mLs per kilo per hour. If they weigh 5 kilograms, and it's just 5 times 4, and it's 20 mLs per hour, right? And that's their maintenance rate. And then for the second 10 kilograms of their weight, it's going to be 2 mLs per kilo per hour, right? So that means if they weigh 15 kilograms, for instance, then you would use that first 10 kilograms as 4 mLs per kilo per hour. So that's 40 mLs per hour already, right? Just off the baseline, but based off their first 10 kilograms. And then they're 15 kilos, so they have an extra 5 kilograms to account for. So now I can say that 5 kilograms times 2 mLs per kilo per hour, that's another 10 mLs. So I can take that 40 plus 10, their total maintenance rate is going to be 50 mLs per hour. And again, you can make up your own patience and practice with this such that you get comfortable with it, because after a while, you'll be able to do it in your head very quickly. For any type of patient, whether you work in pediatrics or not, you can figure it out. For most adult patients, the kind of standard people think about is 125 mLs an hour, even though that may not apply to everyone. It's kind of a one size may not fit all patients there. And this is based off a total of 3 liters per day, but it just depends on the patient. Using the 4-2-1 rule, you can't really get into too much trouble, which is handy. And then, as I mentioned, for every kilogram after 20, it's just 1 ml per kilo per hour. Right? So it'd be 40 plus 20 plus how many ever kilograms you have left over there. So that's generally how it goes. If you have further questions, you can let me know. We can talk more about it. But Savannah says, is it best to memorize the mechanism of actions for the class / type of medication and then remember which drugs go into that class? Yes, I think it is easier to memorize instead of saying, okay, ticagrelor is an ADP receptor blocker, and it does has this mechanism, has these side effects, blah blah blah. Instead, I think it's better to say, okay, ADP receptor blockers. I know that includes ticagrelor, clopidogrel, prasugrel, and then also, what else do I know about ADP receptor blockers? Oh yeah, I know they have bleeding risk. Okay, I know that they're oral drugs, and you give loading doses. That way, they get to steady state faster and they work better, right? I can use them with aspirin for synergy. Those sorts of things there. That's kind of how I think it's easier to do it based off category. And again, on a test question, I'm not going to give you answer choices like COX inhibitor, ADP blocker, or 2B3A inhibitor. I'm going to give you aspirin, prasugrel, argatroban, and something else, right? TPA, and ask you which one of these works on this mechanism, right? That's a pretty simple question because it's just memorization at that point, right? However, I might ask you a question saying, a patient was allergic to aspirin, but they still require, antiplatelet therapy. What's a good alternative? You have to memorize, okay, well, I know aspirin works on COX, but they can't receive that because they had an allergy. What's something I can use as an alternative that gets similar activity, that you can use, for oral therapy for long term? Oh, yeah, I remember you can use ADP blockers, right? Clopidogrel could be a good alternative there. I wouldn't use something like heparin because heparin's not an antiplatelet drug. I wouldn't use something like warfarin because, again, that's an anticoagulant, it's not an antiplatelet. So those are the kind of things I could ask you on a test in terms of applying the knowledge, not necessarily just regurgitating a side effect or a drug interaction or something like that, right? There will probably be some questions like that, but it's not going to be the great majority of them. What other questions do you guys have? Yeah, no problem, Savannah. I'm sure you'll have more questions next week, I'm sure. But again, if you post them on the sticky board, I won't check that until next week. So just FYI on that. You can email me, whatever. No big deal. Otherwise, have a great week. And I'll see you guys around. All right, I'm gonna end the stream. You guys have a good one, and see you later.